Hi everybody, my name is Rhys Barber. I'm one of the audiologists here at Audiology Associates. Thanks for watching our video today. Now this was a lovely lady that came through and said she'd been to a different clinic and they had cleared the wax up, but she felt that she was still having lots of hearing difficulties, and came along to our clinic just for us to take a look, see what was going on. So I did take a look in this side and thought, oh, okay, yeah, we've got this piece of skin here at the top, but the eardrum looks particularly dull. So you can see I'm just lining the forceps up there just to grab this quite thick, hard piece of skin. There we go, and I thought, oh, this is just going to be quite a simple little job. It's just going to be removing this little bit of a skin, probably a tiny bit of a skin peel. How wrong was I on this side? You can see there we've got this quite thick piece of skin, but keep an eye on the canal with this one. I thought this was just going to take seconds, but what we've actually got is a very hard keratin layer that's covering the canal and the drum, and this is why the patient was still having a lot of difficulty. I don't quite understand why the previous clinic had left that piece of skin at the top, and if they just attempted to remove that, they would have seen there was more going on than just a little bit of wax inside. Again, let me give it this minute. A little bit of wax inside that canal, and as you can see here, when we're pulling this down, now I can see that this skin layer goes all the way down the canal. I'm still using the standard size on the tube at the minute, and the reason for that is the skin is actually still, quite a large sheet of skin. If it was coming away in much smaller strips, so it was much shorter, then I would say we need to go down to the fine end just to minimize any risk of clarinetting. But when it's like this, look at this peel, guys. It is just an immense peel. It's going all the way around the canal, and you can see from that eardrum and how it looks. Your eardrum should be shiny, it should be pearlescent, you should be able to get a good, what they call light reflex, so the light was shining in, bouncing back off the eardrum. It's doing none of those things, which means that we know then that there's a surface layer of usually drier skin, and a very thin surface layer of drier skin sitting over the top of the eardrum. Now, when the skin dries out, it dehydrates. That's when you get this kind of harder layer. Now you imagine what's happening here. Your eardrum should be able to vibrate really easily back and forth, and what's happening here is we've got this very sort of thin but hard layer of dry skin that's sitting over the top of the eardrum, which is also connected to the canal wall. So it means that when that eardrum is trying to vibrate, it can't vibrate particularly well because everything's being held up with this tougher surface layer sitting over the top of it, which is why the patient was experiencing some dullness to the hearing. Now what I've done here is I've introduced a little bit of olive oil in here, well, quite a lot of olive oil actually, because when you're working with these very thin layers, it's always difficult because they are usually still quite dry, and especially if I'm doing an eardrum peel, 9 times out of 10 I will pop some oil in just because it helps everything along. Now it's more difficult when we get to this point because we've got this slightly narrower portion to the canal, which means that to peel this you've got to pull from one side to the other like this. Now the difficulty is when you've got a narrower canal, you haven't got a lot of room with that pull. So sometimes what we need to do is what we're doing here. You can see I'm trying to grab it with the forceps. A little bit of a flinch from the patient there, but just trying to grab it with the forceps so that what we can do is almost shear a little bit off, so I've got a shorter piece to work with to do that pull with. I can see that layer down over the top of the drum. So back to the suction now. Couldn't quite get that top layer peeled, so let's try and see if we can peel up from the bottom. But that's also difficult because if you peel up from the bottom, especially in this case, we're going to hit that anterior recess. Now the skin peel's got to go around the bend down to the recess and then across the eardrum. Much harder to get that peel with it. You're more likely to shear it in that recess. So let's try and lift now. You can see I'm peeling from the left, but also trying to lift from the bottom. Tough old one to do this one. I'm looking at that and I'm thinking, okay, I'm holding the forceps at the wrong angle there, so let's just alter the angle of entry for the forceps. Oh, that's a nice grip. Let's see, gentle pull. There we go. So I managed to shear the one side. That's great. It means now that we've got this shorter piece to work with, so we're going to get a deeper peel going. And yeah, this isn't good. This is just going to shear. There you go. You can see that. Just because it was so wispy and kind of almost serrated on that edge there to try and get a grip on that would have been too difficult. But now we've got a shorter piece of skin. I wanted to attach that bottom left section there, sorry. So I'm pulling down from the top I'm thinking, okay, so the bottom left is not detaching, but can we pull the whole skin peel down over the drum? So keep an eye on that eardrum. You can see how dull it looks at the moment. Trying to basically reposition this. I've got a little bit of oil on the camera, so we'll clean that off now. But I'm trying to reposition it so I can get the forceps in, and it's trying to get the top jaw of the forceps above the skin, but without touching the canal wall. And there we go. Look at that. Look at that. Look at that. Do you like that one? How was it going? It peeled that whole left hand side of the drum there. Let's see if we can peel this section off the right. Oh, just got to get a grip. I might have to go back in with the forceps here. I'm not too sure what I do with this one. I can see it doesn't want to peel particularly well, but it does look like one that's good for the forceps as long as we can get a good grip. There you go. Always difficult when you're this deep with a forceps. There we are, there we go. So it's peeling now out of the anterior recess and that bottom section of the eardrum. Look at that peel away there, guys. Look at that. And then we got one more piece peeling down the canal. Look how this is peeling down that canal as well. There we go. And let's take a look at the eardrum now. Very different looking eardrum from when we started, and patient hearing so much better on that side. Really, really hearing well. Now, this was the reason they came in to see us, was because they had this very, very deep section. And in fairness to the clinic, they recommended they come to see us because they just couldn't get this last piece out, and the patient had been back and forth. I think it was 3 times, and they just couldn't budge this last section. Now, obviously, when we're using the endoscope, we get a much, much better kind of deeper view. I love the endoscope. It really, really helps. But what we've got here is a very thick, dead skin layer. Now remember what we saw on the other side. Now what's happened here on the other side, it was the whole surface layer of the canal that had dehydrated and sort of got this much harder keratin feel to it. What we've got here is it actually, rather than the whole canal wall that's done this, it's a very specific section right in front of the eardrum. So almost all the skin is dried out onto the drum itself, and it's left this really thick skin plug, which is really firmly attached in here. So what you can see I'm doing here, look at the movement. I'm getting a little bit of movement. The whole thing appears to be moving a little bit, and the patient was, bless her, she was so desperate by the time she got to us, because she's been like this for such a long time and was getting nowhere, unfortunately. But look at this. Look at that for a skin plug. Now, a lot of the time when you take these away, what you're left with behind then, excuse me, sorry, is a very kind of messy looking eardrum, because the skin hasn't been migrating off the drum particularly well. And that's what I can see here. So you can see it's just left this sort of very thin layer of, it's kind of like almost like a dead sort of skin or keratin layer. But what we'll see here now, as I try and lift this, it's really firmly attached to the canal, to the eardrum itself. So I'm going to get away what I can. And my advice to this patient then is, because this is all dead skin that's been kind of hanging around in here for a long time, because it's really firmly attached to the eardrum, you don't want to go in there and try and sort of pull that away. But look at this section. Look how deep that was there. That has such a deep kind of section of wax there. So you can see to the top left there, you've got this kind of almost, it's not a hole in the eardrum, but it's a hole in the dead skin there. But that is so firmly attached. So my advice to this patient is going to be, I want you to use oil on a regular basis, which is going to help. Look at this, watch. Look at this, look at this. It's a delicate peel, this one. I'm trying my best to peel this down. Look how firmly attached that is there. Look at that. This eardrum does not look particularly healthy just because it's had this keratin layer on it for such a long time. Look at it peel, look at it go. You can actually see it just an ever so slight flex to the drum there as well as that was peeling away. So this is not like the other side. We had a kind of dry skin layer that was sitting over the top of the eardrum. In this case, it's a very thickened kind of drum, so a lot of keratin sitting on the surface. So that surface layer, this epithelial layer, we talk about epithelial migration on the channel a lot, which is the movement of skin off the eardrum to form the surface layer of the canal wall skin. Now what we've got here with this epithelial layer is it's not migrating off, it's sitting in place, in situ, and hardening. So instead of getting this migration off the drum, you're getting these layers that have built up one after the other on top of the drum. So with this patient, unfortunately, it's going to be a regular visit for this patient. So you're going to be seeing this patient probably at least every 6 months, just to remove that surface layer. There's no rhyme or reason as to how it happens. Sometimes, you can put it down to infection, causing a little bit of scarring or interrupting that migration process, and then you end up with this moving forward. But I think for this patient, you could see there was a tiny little flinch there. Obviously, this is super sensitive in this area. So I've just tried to push against it and just to see if I could just take that last little bit off, but the patient flinched. So I'd rather get the patient back every 6 months and just give it a thorough clean every 6 months. So 1 13/16, that's really hard to say, of an inch, 4.5 centimeters, all skin. Told you it was a good one, didn't I? I enjoyed it. I leant forward for most of that, so I obviously enjoyed that myself. Well guys, thank you so much for watching our video today. If you do enjoy the videos, don't forget you can always like, heart, share, follow, subscribe. If you thoroughly enjoy the videos, you can also consider becoming members of the channel. That way then you get to see even more videos every single week. But guys, until the next time, where it'll be a few more of us next time, take care of yourselves, take care of your ears, and take care of one another, and I'll see you tomorrow. Bye everybody.